Hi everybody, I'm Dr. Paul Houle. I'm a neurosurgeon from Cape Cod, Massachusetts. And by now you've completed your initial training into endoscopic spine surgery, and we thought it would be interesting for you to see how someone like myself and like yourself got started in introducing the JoyMax procedure into your practice. So just a little bit about me. I'm one of actually now 5 physicians in a 5 neurosurgery group in Cape Cod, Massachusetts, and our patient population is one of the oldest in the United States. We have the oldest county in the U.S. I personally have been in practice for 16 years, and I perform about 90% spine. I've always performed my lumbar discectomies and laminectomies through a tubular retractor utilizing the metric system. All of my patients, or all of my surgeries are always outpatient surgeries, and I perform a large volume of kyphoplasties. And that's important because it really helped with conceptualizing needle placement. As far as my past experiences with minimally invasive spine surgery, I did help develop the MIS T-lift system from DePuy called the Expedient system, and that gave me some familiarity with the anatomy of Camden's triangle, although at the time I didn't know that it was Camden's triangle. I have also performed epidural steroid injections by myself. I also perform a large volume of kyphoplasties, and like I talked about, it really helped with familiarizing myself with needle placement. So how did I get started? Well, my initial exposure was with a trusted local spine rep who knew my practice. I really believe in sparing the paraspinal musculature if you can, and also sparing the facet joint, because I think this is a significant cause of postoperative pain in spine patients. I did do a visitation, and the most important thing that I learned from my visitation experience was that these procedures can actually be performed under local anesthetic. So that gave me the confidence that this procedure could be done. I did visit Dr. Albert Telfian at Brown, and he's one of the pioneers of endoscopic spine surgery in the United States. And I performed, I went to a cadaver course taught by him, and I learned quite a bit about endoscopic spine surgery from him. I did approximately 5 endoscopic spine surgery cases with a technical specialist from JoyMax. That was Brian Duda. He was very helpful in guiding me and giving me the confidence to continue and to do these procedures successfully. I then went to another cadaver workshop where I gained some even more experience. And I did about another 20 cases or so. And during that time, I would text Dr. Telfian, hey, do you think this case would be a good one to do? And do you have any advice? And he'd always text me back. So it was really important to have that mentor. And then I was fortunate enough to participate in an international visitation program where I was able to go visit Dr. Iprenberg in the Netherlands and also Dr. Florian Alphen in Würzburg, Germany. And again, that just gave me more confidence to be able to do the procedure. So for my first cases, I chose an extraforaminal disc, and the reason I chose that over a paramedian is that, you know, what you've learned in the lab is that you tend to be a little bit lateral because you're so afraid of getting into the dura that your natural tendency is to be a bit lateral. So I thought that if I would choose an extraforaminal disc herniation so that if I were lateral, at least I'd be on the pathology. I did not do an L5-S1. I chose, I think, an L3-4. I started doing my cases in the prone position because I didn't want to change too many things at once. So I did my typical patient prone on a Jackson table on a Wilson frame. And I had my fluoroscopy machine and the JoyMax tower opposite me. So I was in a very comfortable position. The needle placement obviously is the key to the procedure. So what I recommend is really take your time with this part of the procedure. Especially when I teach the courses, I tell people that you know, placing the needle sometimes is the vast majority of the time for the case. So really take your time and get it right, because everything follows from your needle placement. If you see in this the x-rays that I have provided, you notice that on the AP, the needle looks like it's in a great position, but if you take a look at the lateral, that needle is in the disc space. So this is actually a little bit lateral, and I put that up there to demonstrate this. Again, the tendency is to be too far lateral, and I try to teach that you just can't be too medial. Of course you can, but the point being is that the more medial the better, especially if you're going after a paramedian extrusion. One of the other lessons that I learned when I started doing the L5-S1 level, especially after I got back from the Netherlands and visiting Dr. Ippenberg, was to use the curved dilator. And so some of the cases that I'll be presenting in other presentations online will be the use of the curved dilator, so stay tuned for that. And just keep in mind that this is not an intradiscal procedure. This is an epidural procedure. You want your scope and your working channel to be in the epidural space so that you can visualize the exiting nerve root, the traversing nerve root, and the dura. I think the most painful part of the procedure is when you're performing the reaming. So I ask anesthesia to increase the sedation during the reaming. You also have to be careful because anesthesia wants to tend to over-sedate. And so you really have to have good communication with your anesthesiologist. In your packet, you received the anesthesia options, and I would share this with your anesthesiologist. I also keep a PDF version of this on my Dropbox account, so if there's a new nurse anesthetist or a new anesthesiologist that I'm not used to working with, I can show them the guide before surgery or email it to them so they have a chance of reviewing it before the procedure. One caveat we found is that older patients do not react well to ketamine. So some anesthesiologists like to use ketamine, but it's a dissociative anesthetic, and sometimes the older folks tend to get a little crazy. Inevitably, you'll get some epidural venous bleeding. It's a little bit worse when you're in the prone position. It's not so bad when you're in the lateral position, but if you do get bleeding, and sometimes you can't see where it's coming from, simply place your finger over the end of the endoscope, and the water pressure will build up enough so that it'll tamponade, and after a few minutes it usually slows down enough that you can get the bipolar in there to coagulate the bleeding vessel and then continue working. Sometimes, and this happened to me just the other day, I couldn't control the bleeding that went. I just couldn't see what I was doing. So all I did was take a little bit of Surgiflow and put it down the working cannula, placed the endoscope down, waited 2 or 3 minutes, and washed it away, and the bleeding stopped. So keep that little technique in mind if you do get into some bleeding. When I was in Europe, both surgeons did the procedure in the lateral position, and it's not uncommon in the United States for discectomies to be formed in the lateral position. I had never done it, but I saw how comfortable the patients were, how comfortable anesthesia was with the procedure, and I thought that if other surgeons have done thousands of these procedures in the lateral position, there's no reason why I couldn't do it. One of the advantages of being in the lateral position is if one of your physical exam findings is a straight leg raise sign, well, while the person's in the lateral position, you can perform that maneuver during surgery, which aids you in determining whether or not you've adequately decompressed the nerve root. For my setup, it's a Jackson table with a flat board. The fluoroscopy is at the foot of the bed, as is the Joymax tower. The patient lies in the lateral decubitus position with the affected side up, and I use a plastic drape wall similar to what you use in, or what orthopedic surgeons would use when they're fixing a hip. And as odd of a position as it may seem, it really took about 2 cases to get comfortable doing the procedure in the lateral position, and I've been doing it ever since. I really like the fact that the patients get themselves on and off the table without too much effort. So for your first cases, I chose a nice little lateral protrusion causing the compression of the exiting nerve root in the distal foramen. Here's another example of a lateral protrusion that I did, and this is my first L5-S1 disc herniation that I did. So in closing, this is a truly minimally invasive, a muscle-sparing procedure. You have the ability to resect your superior articular process, and I think this is the key difference between this procedure and some of the other procedures that have been performed endoscopically. This is not an inside the disc procedure. This is truly an epidural procedure. By resecting the supraarticular process, you have the ability to widen the neuroforamen. Patients tolerate monitored anesthesia care and local sedation, local anesthetic and constant sedation extremely well. And it gives you the ability to have the patient tell you when you've removed disc, because they will tell you, oh my goodness, my pain's just gone away. The fact that you're able to perform a straight leg raise sign if you do it in the lateral position further gives you the confidence you've done a good procedure. There will be times where you'll question whether or not you want to continue doing this procedure, because it is difficult. But if you persevere and have confidence in yourself, you'll get more experience, you'll get better at it, and you realize what a wonderful procedure this is and will truly benefit your patients. I often refer to the technique video that Dr. Ippenberg did a couple years ago. It's on YouTube. It was also in your packet. Refer to that frequently. And of course, anytime you have questions, just contact me. There, my contact info is on the screen. Also, please join our Facebook group. You can ask questions there. Thank you very much for watching, and I really wish you the best of luck.